us make informed decisions about best use of therapeutics. And you've got now this class of drugs, represented by ibrutinib, that are very much, dependent on the MYD88 and CXCR4 mutation. And if your doctor has that information, they can kind of leverage how these drugs, how they should fit into your particular care. And it's not just, upfront. It's not going to be something that your doctor is going to think about just the first day they meet you, if this is the first time you're being treated, but it's going to be something that's going to follow you, because no matter what your treatment is, at some point you're going to see one of these BTK inhibitors, and how you leverage them will be very much dependent on those mutations. And let me also just leave you with one thought. It's not just about ibrutinib. As more trials are coming around, we're learning about how CXCR4 is able to affect other drugs. Like, for instance, in the trial that Dr. Castillo did using the drug ixazomib, he found that if you had the CXCR4 mutation, it took longer to get into a response. We also know from the study that happened in France, where they looked at bendamustine and Rituxan, the patients that progressed earliest were those that didn't have the MYD88 or CXCR4 mutation. And so this also tells us a little bit about the urgency of needing to develop better therapeutics. So I think as of today, knowing what one's MYD88 and CXCR4 mutation status is can really help tremendously in our ability to rationally figure out what therapeutic approach is needed today, as well as what we should plan on for tomorrow.
Thank you. And you mentioned that specifically with relation to ibrutinib. Would that apply as well to bendamustine? I think I heard the mention of that earlier.
Yeah, so, what we know as of today is that bendamustine-based therapy is affected by the MYD88 status based on that one prospective trial. CXCR4 did not, impact how those patients did in the Philo trial that was published just recently. So it's MYD88, not CXCR4. Yeah.
Hey, Dr. Treon. Hang on. Check, check, 1, 2. Spaghetti and meatball. All right, whatever. There seems to be a lot of second-generation ibrutinibs or BTK inhibitors coming out. We heard from Dr. Castillo about the umbralizib. Then you were talking about the zanubrutinib. And I saw a bunch of others that I don't even remember. Are there any that are like the most exciting or most targeted or might have the least side effects that you think?
Well, let me start with the question. I don't know if everybody heard was, we've got all these new BTK inhibitors coming. Are any of them showing, any particular promise, and are any of them more targeted? The first thing just to tell you is that being more targeted isn't necessarily a good thing, because as we learned from an early BTK inhibitor, it was a drug that Celgene and prior to that Avila had created. It was too clean. It only went after BTK, so it wasn't promiscuous. It only went after that one target. Now, this is an example where being promiscuous is actually a good thing. And in the case of this particular, example with ibrutinib, it not only hit BTK, but it also hit HCK. And what you got to also remember is that that's just, the icing on the cake. These drugs all have multiple targets. And as we've been deciphering out what their activity is, those targets can be within the cell, things like HCK and others, but they can also be in the environment. And that's a very important lesson, because what drives Waldenstrom's has to also do with the microenvironment, what they're getting, what these cells are getting in the bone marrow. Those cells include cells like mast cells. We've reported on this many times over. If you look at your bone marrow biopsies, many of you will see increased number of mast cells found in your bone marrow. Mast cells are usually the cells associated with allergy. And then we also have, macrophages, which are also cells in the bone marrow. And these cells are actually feeding the Waldenstrom cells with protein signals that allow them to grow and survive. And both BTK and HCK are present in those cells that we're able to shut down. So it's not only going after the internal machinery of the cell, but also silencing all the contributors to the growth and survival of the cells. And that's why we're going to see differences in these kinase inhibitors. And ultimately, it's going to take a randomized clinical trial like the one we see now for zanubrutinib and ibrutinib to be able to tell us what those differences are. Now, there are also logistical, differences. Ibrutinib is given once a day. Zanubrutinib is given twice a day. The latter may be perhaps, advantageous if you think about drug coverage. On the other hand, it also means somebody has to take the drug twice a day. So those are all the differences that, a randomized clinical trial will answer. And then there's side effects. There may be very different side effect profiles, in time that we will see in these randomized trials, but so far, based on what we have seen from the phase 2 data, they all seem relatively comparable. Now, if you have somebody who has a side effect on ibrutinib, having these other drugs is also exciting because maybe you can switch them over instead of, abandoning BTK inhibitor therapy. So being able to leverage all these new drugs to us is a very exciting opportunity.
Cool, thanks.
Two questions. As I understand it, does zanubrutinib hit HCK?
We don't know. We don't know. The kinome profiles, for these second-generation BTK inhibitors is less clear. So there's no published kinome profile that I've been able to access.
Those are easy assays.
Yeah. Well, I know.
But
Somebody has to do them now.
But let's say it doesn't hit HCK, just to suppose. I wonder if you could combine it with dasatinib to get the HCK activity.
So potentially. Although we're doing now a dedicated trial with dasatinib, and that's being run by Dr. Castillo. And dasatinib, as you know, is a very potent HCK inhibitor. That trial will actually teach us a lot about the importance of HCK as a target. But also, what we're trying to do in that trial is to look at ibrutinib-resistant patients. Since HCK turns on BTK, what we're actually hoping is that by shutting off HCK, we'll also be able to shut off BTK, even if it's mutated. Combining these down the line, I think, potentially has merits. One has to keep in mind that dasatinib tends to have its own share of toxicities, but it does represent a potential way forward. And I'm excited that Jorge is doing this trial. We were able to finally get funding for it. The company gave us the drug, but didn't give us the funding. So Dunkin' Donuts stepped in and provided us one of its breakthrough grants. So if you just happen to be around a Dunkin' Donuts, I encourage you to be a user.
And the second real quick question is,
yes.
I'm trying to think of things that you didn't talk about, which is not a whole lot.
You got less than 10 minutes.
But well, as long as you're doing all this sequencing, what about looking at CD16A for the polymorphisms to try to predict a Rituxan response? V versus F.
Already done it, published it, and that was in 2005, I believe, or maybe even earlier than that. So we did look, and I don't know, just to bring everybody up to speed, there are polymorphisms in our cells that determine how well we respond to rituximab. And these are the receptors that actually the immune cells have that engage the rituximab. And we were pioneers. I have to say, give Waldenstrom's another round of applause because we were among the first to actually, make this discovery, and it was published also at the time in the Journal of Clinical Oncology. So, that's a very exciting moment for Waldenstrom's. The problem is that once you start combining chemotherapies, you can actually negate the effects of these polymorphisms. And so as a result, since most of the time we use the 2 drugs or 3 drugs together, that we're able to overcome the polymorphisms. But if you're using Rituxan by itself, it certainly is it's worth considering. There was a company that actually offered this, and over time it went bust. I think it got even bought by one of the other molecular diagnostic laboratories, and it really didn't have much more clinical utility. But that's what we're getting at with MYD88 and CXCR4, that now with the current drugs that we have, the BTK inhibitors, being able to personalize our approach to treating patients is much like we tried to do with Rituxan and the Fc gamma R3A variants.
Okay, thanks.
All good questions. Give this gentleman a round of applause. Those were very good questions. Okay, last question from Pete.
Thank you very much. One quick question here. You suggested
It's
that
never
I
a quick
think
question with Pete.
that ibrutinib evolved mutations. I think that's what you said, rather than the mutations were pre-existing and they were shown to be there. Are you saying that ibrutinib and maybe venetoclax is mutagenic?
No.
Thank you.
I'm going to run over my 10 minutes here, Pete. As best as we can tell, these, and I'm only going to talk about the ibrutinib-related resistance mutations. As best as we can tell, these things are pre-existing. And what happens is, as you put the selective pressure of a drug, these are the clones that are actually breaking through and growing. Now, it's hard to prove this other than through inference, because these are like in the 1 to million, clones. And we don't have the ability today to test out, those kind of mutations at that frequency. But you are seeing this happening across the board in all the diseases, and we don't see it at before the patients start on therapy. And that's why we're all inferring that they exist and that the drugs are unlikely to be mutagenic. Yeah. Okay, give yourselves a round of applause. Great questions. Thank you very much.
Okay, you've now earned yourself a break. Breaks the usual.